Thank you very much for the kind introduction, and I thank all of you for giving me this opportunity to come here. I can add Lucknow to the list of places I visited in India. You people are special. Thank you. Hmm. So, and I'm very impressed by the facilities at this institute and the quality of the teaching and the clinical work that goes on here. It makes me feel proud that you are carrying on in the best traditions of Indian medical science. So today I am going to discuss the role of the biopsy in liver transplant recipients. Of course, we need biopsies to establish the primary cause of graft dysfunction. And sometimes there's more than one cause. Then you identified concurrent pathology. There might be TCMR, but also ABMR and drug injury and ischemia, all in the same biopsy. So transplant pathology can be complex. The biopsy helps to assess the severity of injury, and it assists in the planning of therapy. You can use the biopsy to determine response to treatment and to document relapse when it occurs. So it's a very critical piece of investigation. There are some general principles of interpreting allograft liver biopsies. The most important one is to remember that the transplanted liver is really a liver. So it will have the same pathology as the pathology you see in non-transplanted livers, but there are some peculiarities. There'll be preservation injury, there'll be rejection, there'll be opportunistic viruses, there will be PTLD. Sometimes there will be graft versus host disease. And the final diagnosis should always be based on a discussion with the clinicians. So you should discuss every biopsy with the hepatologist or the surgeon before you render a final diagnosis. And when there are multiple causes that you're seeing in the same biopsy, you should try to list them in the order of importance so that the clinicians also know what's the most important cause of dysfunction, what's number 2, what's number 3, and so on. And that's something which is useful for clinical management. Most of the diagnosis can be made on routine stains. I will mention a few special procedures. We talked of microvascular inflammation. Dr. Vidge demonstrated that. So just like in the kidney, we have actually started doing PASD stains on the liver because you can recognize the capillaries better. And similarly, the trichrome is, of course, an essential stain to quantify fibrosis. C4D in our hands is routine, but that's because of our academic interest. Of course, the incidence of ABMR in our program is also low. We maybe see maybe less than 10 cases a year. Our cytokeratin 7 is also routine because especially when you're doing living-related transplantation, no matter how good the surgeons are, there's an incidence of biliary strictures, which varies with the experience of the surgeon. It could be anywhere from 5% to 40%. And so we like to screen every biopsy with CK7. So if we see periportal metaplasia, ductal hepatocytes, then we communicate that to the surgeon. That just make sure that the biliary tree is functioning well. And similarly, once in a while, you will need to stain. CMV has now become very uncommon since the initiation of prophylaxis with ganciclovir. But you have to remember these viruses because once in a while they will occur. And if they're not diagnosed, the outcome is bad. And for when you're suspecting PTLD, you have to stain T cells and B cells, CD20, and you have to do EBER, and you have to do kappa and lambda to see if it's clonal. And the CD20 is very critical because if positive, then you can treat those cases with rituximab. Electron microscopy is occasionally necessary when the viral suspicion is strong. You may have to use adenoviral or herpes virus demonstration might be on electron microscopy. So these are the diseases. So these are all the diseases I'll cover. You don't have to read it. All right. So the one important thing to remember as in any transplanted organ is when you're looking at a pathology, especially if it's in the first few weeks after transplantation, you have to at least consider the possibility that whatever you're looking at was there in the donor liver. And that's especially true. 1/3 of America suffers from obesity. 1/3 of all liver transplants are due to NASH. And so especially if the donor liver is not biopsied, much of the fat that you will see in early post-transplant biopsy is probably derived from the donor. And similarly, if the person had an agonal event in the ICU, lived in the ICU for a month before he died, and using that liver, when it comes in, will have a lot of ischemic damage. And similarly, hepatitis C is another well-known example of transmission from the donor. I'm not sure why it skips his slide. Any suggestions why it's happening? Is there some setting that I can change? Let me continue talking. So one of the important things about steatosis is that sometimes before putting the liver in, because most of the transplantation, at least in our centers and most American centers, is deceased donor. It's not living related donors. And so we have the opportunity to look at the liver before we put it in. And whenever a liver looks fatty, that's one of the reasons you biopsy. And so when you are asked to evaluate a liver for steatosis, you have to categorize it as macrovesicular and microvesicular. And macrovesicular assessment is done at the low power. And the small droplet type, you don't often give an area, but you say mild, moderate, or severe. Microvesicular steatosis is not common in allografts, but the causes are the same as for non-transplants. So I should use this, not this? Okay. All right. Well, the problem is there are some floating controls, whatever that means. So that's what has been fixed. All right. So what is, how should you define large droplet macrosteatosis? In BAF 2019, they suggested that you see distension of hepatocytes to 2 times the normal, what you consider is normal in that liver. Other definitions have been used. For example, some say you want to just look at the nuclear diameter and see if it's 2 times larger. Some want a peripheral displacement of the nucleus by the fat. Well, whatever scheme you are used to, it probably doesn't matter, but it would be good to follow BAMF, I guess, so that we all start using the same criteria. If the low power shows the fat, macrovesicular large droplet fat to be less than 30%, most people consider it insignificant. If it's 30 to 60%, there's a significantly higher risk of graft failure. For example, in one study, there was a 30% incidence of primary non-function versus 5% control. A second study, 1 month graft survival was 76% versus 89%. And the third study, 1 year graft survival had fallen to 53% from 85%. So for that reason, most people are very cautious when the liver is between 30 to 60%. And more than 50% or 60% people probably would just not use it because there is a high incidence of the fat just breaking down and clogging the sinusoids. It's called lipopiliosis. I will show you that. You can even get fat emboli. If you have a lot of fat, there's necrosis, you can get fat embolism. What about small droplet macrovesicular steatosis? It's the reverse of what I just said. Usually you evaluate at 200x, and the droplets are typically occupying less than 50% of the cytoplasm. Nucleus is central. It's not generally believed to impact graft function, although there's one study which said if it's more than 30% small droplet macrosteatosis, they reported a hazard ratio of 2.5 for acute rejection and 2.4 for ductopenia. Surprisingly, in this study, they reported no adverse outcome for large droplet macrovesicular steatosis, which is a little strange. So I have a feeling it's a nomenclature problem. What they are, what they're calling small droplet may not really be small droplet. What is the reproducibility of the steatosis assessment? This is an art. It depends on the experience. Even when you have BAF experts, if the fat is assessed, is judged to be moderate to severe, estimates between 3 experts vary from 30% to 55%. For the lesser involved livers, they varied from 5% to 15%. So the surgeon should be aware of this variation, but this variation is still useful. An estimate is better than no estimate, but you can't get fixated on numbers. Is it 45? Is it 50? Is it 35? Don't ask your pathologist that question. Just take his number and get the overall fee, and then use that number in conjunction with other features. And the less experienced observers, they tend to overestimate the fat because they will even count the smaller vacuoles as macro. So you should avoid that. And the expert surgeons take your number and they integrate it with the gross findings and with the liver function test. They don't just ask you, should I use it? Should I not use it? They take your input and then put it together with everything else. And sometimes biopsies are done at a different center than yours. And we are of recommending that we make actually whole slide scans available. Our Center for Core Organ Recovery and Education makes whole scan slides available to other centers. Sometimes we get requests from other surgeons. Can you send me a photograph? Or do you have an iPhone? Can you take a picture and send the picture to me? I refuse. I said, this is not good practice of medicine. We are happy to make the whole slide scan available to you, and you should review it with your pathologist rather than choose to make a decision based on whatever field I give you. And some people don't really understand it. They think you're not being cooperative, but you try to tell them that that is not the best way to practice. And as I said, stat alone should not be the criterion for using or not using a liver. The percentages can become less acceptable, more acceptable if there's other pathology. If there's necrosis of the hepatocyte, if there's dropout, even 30%, you have to be careful. Should I use it? Because now it's more than one hit. Cold ischemia time, if it's very long, you have to take that into account, whether you should use it or not. The surgeon and experienced surgeon's gross assessment. The liver may be mushy, not even worth putting in. He may already have decided. But the biopsy is not going to show you. And there's no anatomic counterpart to mushiness. So the gross evaluation is also important. And then the arteries at the hilum, if they are calcified, even if the biopsy is looking good, the liver should not be used. Or if it is used, there has to be a separate graft which bypasses that calcific area. So the pathologist should be aware of all this, because sometimes the surgeons simply put them on the spot. So use it or not use it, then that's the time for you to start asking questions. What is this? What is that? And then you help to guide them to a more reasoned judgment, rather than simply having them decide based on the percentage of fat. And the nature of the recipient matters. The same liver, if given to a younger patient, may function better because they have more regenerative potential, and it may function less well in older patients. And sometimes I joke, this liver is not good for my mother, but it's good enough for my mother-in-law. So the nature of the recipient is also important. And then, of course, if there's a high MELD score, if the person is going to die in the next 4 weeks, it's better to give a liver and maybe hope that it works and avoid certain death. So that's it, because there is no dialysis counterpart in liver transplantation. That is. So microvesicular steatosis is seen in sepsis, viral infections, trauma, drugs, and so on, and it has metabolic causes, and most centers find it resolves on follow-up, and we don't grade it. Sometimes they ask you, what is the percentage of microvesicular steatosis? Then we just have to tell them, we do not grade it, and we do not recommend that you take that into account. But since they ask, we will tell them a broad idea, mild, moderate, severe, at the same time emphasizing that don't use this in your judgment. So some examples. These are macrovesicular globules. A caveat is that if a liver biopsy is exposed to saline, you can get swelling of the hepatocytes. They can look very pale, as you can see here. So if you are in the position of doing frozen sections, you should be present at the time a biopsy is done. It should not sit either on a gauze and dry up, nor should it sit in a container with saline for a long time. So we are there when they give us the biopsy, and we freeze it and tell it right away. And on a frozen section, irregular dilated sinusoids can be confused with fat. Now, some of these are obviously sinusoids. Nobody's going to call them fat. But what about this one? What about this one? On a frozen section, you have to remember that sinusoids can look like vacuoles. On a frozen section, intranuclear glycogen can look like vacuoles. So why is it intranuclear? Because you can see a rim of chromatin around it. So that's another caveat to remember when you're interpreting frozen sections. This is, of course, that severe 60, 70% steatosis. I mean, one look, you're not going to use this liver. And this is what I call lipopiliosis. When a very fatty liver is put in and you get a lot of severe ischemic reperfusion injury, the fat globules will coalesce to form larger globules. And just piliosis refers to dilated sinusoids. Here it refers to lipopiliosis, large fatty globules. And they can, as I mentioned, enter the circulation and cause fat embolism. Let's talk of preservation reperfusion injury. It's best looked at as the cumulative effect of agonal changes before death. Cold ischemia time, warm ischemia time, reperfusion injury, post-reperfusion or post-transplant flow problems such as hypotension, anesthesia. So it's a multifactorial thing. Some people present as a hepatocellular injury pattern with the elevation of ALT and AST, but some people present with a cholestatic injury pattern. And they may even have jaundice and biliary sludge syndrome. And ischemia sometimes has an effect on the matrix. It dissolves away the connective tissue and it produces hepatocytes like this, which we call hepatocytolysis. This can also be seen as an artifact if you are putting the biopsy in saline for too long. Again, it is, oh, I forgot the advice they gave me. They asked me not to use the mouse, but to use this arrow. So let me put it here if I can. Yes, so ischemia reperfusion, I'll show you the spectrum of ischemia reperfusion injury. The milder forms will just have clusters of neutrophils in the sinusoids, apart from hepatocellular swelling. More advanced injury would have areas of hemorrhage and hepatocyte dropout, periveneral dropout, and neutrophils can occur around the central veins if the ischemia is severe. And then if it's really bad, you will get centrizonal hemorrhagic necrosis. So these are examples of cholestatic injury. These apodotrax edematous, there's cholangeral proliferation, they are neutrophils. That's actually what we saw in the case this morning where there was a stricture. You can get ballooning degeneration, even Mallory's hyaline-like change. And if there is lack of flow to the bile ducts, then you would get bile duct injury. So you'll see areas of ulceration and denudation, and then secondary inflammation. And yes, you can even get large casts, the bile casts forming, or you can call it a microlith. So early biliary complications, they are reported in 19% to 23% of patients. Each such biliary complication can add more than $54,000 to the cost of healthcare in the first month. So we should really try to avoid it. The possible causes are strictures at the anastomotic site, early post-transplant, we look at the anastomotic site. They may manifest as leaks, bilomas, casts, fistulas, ischemic cholangiopathy, ascending cholangitis, abscess formation. The risk factors are deceased donor livers, long cold ischemia, donor arteriosclerosis, CMV infection, acute rejection, TCMR if it causes arteritis, and even antibody injury can cause damage to the biliary capillaries. So there can be rejection causes of biliary complications. Late biliary complications include strictures. They will tend to be non-anastomotic, ischemic cholangiopathy, then recurrence of diseases such as primary sclerosing cholangitis. Chronic rejection, TCMR with graft arteriosclerosis will lead to ischemia. Chronic ABMR with injury to the biliary plexus will also lead to cholangiopathy. And here are some examples. This is an example of a bile leak and extravasation. This is a bile infarct, an area of dropout with inspission by bile. Here's a large microlith. A gross examination may show dilatation and stricturing. And here's periductal edema, fibrosis, and focal ulceration. Let's talk of vascular complications. An important thing to remember is your medical school lecture, which tells you that the hepatic artery is the only supply of the bile ductal epithelium. The portal vein supplies 75% of the blood in a normal person's liver. So if there's hepatic artery problems, you would get bile duct problems. So those can happen in thrombosis or chronic T cell rejection, as well as in antibody injury. So very briefly, let's talk about hepatic artery thrombosis. Incidence varies from 2 to 20%. Typically, within 30 days, there's a presentation with fever, leukocytosis, liver function tests being enlarged or elevated. The risk factors are long operation time, arterial conduits, variant anatomy, pediatric organs, and low volume transplant centers. The less experienced surgeons get more of these complications. And I mentioned the associated pathology, which can include CMV. CMV can infect the endothelium of the hepatic arteries, T cell rejection, antibody rejection. Early biopsies can be normal. So you can have hepatic artery thrombosis documented radiologically, but the pathology at the periphery might be normal. And late pathology might include infarction and cholangitis and abscess formation. Here are some examples. So this is an artery partially occluded by a fresh thrombus. Here, the ulceration has led to bile leakage. Bile is a foreign substance which excites an intense chemical reaction. So that can cause necrosis in the surrounding area. The necrosis may undergo super infection. This actually is Candida growing in this necrotic bile duct. You can get areas of periportal hemorrhage, and you can get areas of frank infarction. So that's the spectrum of changes in hepatic artery thrombosis. And here are some gross pictures. Thrombi, subcapsular infarcts. As in all organs, the area most away from the hepatic artery, that is under the capsule, will suffer the damage. And so one of the things we recommend when you're doing donor biopsies is to not just give a needle, or not just give a wedge, but also give a needle. So sometimes the ischemia will be hyper accentuated under the capsule. And we usually recommend both the right and the left lobes be biopsied, and we ask for a wedge as well as a needle. And these are examples of abscess formation, and this is an infarct. Microscopic pathology. You can get blood in the bile ducts, and small amounts of red blood cells actually can even occur if you after a percutaneous cholangiography. But larger areas of hemorrhage, they suggest a fistula. For example, if there's a fistula between the portal vein and the bile duct, you will see bile in the duct lumen. So that's a serious, sign. If you see bile in the portal vein, that again tells you there's a fistula between the portal system and the biliary system. So if you were to show this picture to a poet called Ghalib, he will say, "Yahan khoon ki Ganga beh rahi." Let's now talk about portal vein stenosis or thrombosis. It has a lower frequency than hepatic artery thrombosis, just because the flow is larger. Risk factors include persistent collateral, small portal vein diameter, reduced donor size, pediatric transplant, use of interposition grafts. The early clinical presentations will be abdominal discomfort, variceal hemorrhage, ascites, splenomegaly, liver function test abnormalities. An important word you should remember in late presentation is portal biliopathy. So when you have portal hypertension and you have varices, those varices can form around the bile ducts, and they can cause physical compression. So you can get a whole mass of dilated veins, which can cause bile duct obstruction-like syndrome. So bile duct can not only be hepatic artery thrombosis, portal vein thrombosis, they can be portal vein stenosis. And later, of course, you'll get septic phlebitis, abscess formation, and acute hepatic failure. The pathology in the early cases of portal vein thrombosis may just be periportal or mid-zonal atrophy. You will get dilated inlet veins, and you can get obliterated veins. Late pathology includes nodal regenerative hyperplasia, Dr. Vish showed, and you can get necrosis of varying degrees. And these are examples of nodular regenerative hyperplasia, which already been shown. I can skip it. And one important concept to remember here is the so-called hepatic artery buffer response. In the normal liver, as I mentioned, most of the lobule is supplied by the portal vein. Only the periphery around the ducts is supplied by the hepatic artery. So if there's portal vein stenosis, the hepatic artery compensates and increases in size, and there's increased blood flow to the liver, and that is postulated to be a cause, a contributory cause of the nodular degenerative hypertension. So let's talk of hepatic vein outflow obstruction. It can occur at the level of hepatic veins or the vena cava. The early stages cause just discomfort and transaminitis. Late stages can cause Budd-Chiari syndrome. And when you are looking at a case where you think it's hepatic venous outflow obstruction, think of commoner causes: congestive heart failure, thaw pulmonale, constrictive pericarditis. They will be commoner than actual thrombosis of the cava. And these are classical cases. Budd-Chiari syndrome in the Robbins textbook of pathology described the nutmeg liver, alternate areas of fatty change, the yellow, intense congestion and hemorrhage, which is red. And here on the higher power, you can actually see a thrombus occluding this vein. Microscopically, the earliest form of outflow obstruction is a red blood cell in the space of dish. You can see that here. Then they will be dropout. And then you can get large areas of necrosis. Small for size syndrome, I mentioned this morning. This is a portal hyperperfusion syndrome, which occurs in living donor transplantation. It's essentially a size mismatch between the donor and the recipient. It can cause severe portal hypertension. These are often cases of severe portal hypertension before liver transplantation. And if to such people you give a small graft, the high portal pressure quickly damages those small organs. What is a reduced size allograft? I think surgeons have various criteria. I've listed two of them. For example, if the graft volume is less than 30% of the expected liver volume, you're giving a lobe which is probably too small. And maybe we can have some surgeons comment on this after. And similarly, you can also get a ratio of graft weight of 0.8% to the recipient body weight. The typical presentation of small for size syndrome is within a month or within a week with transaminitis, ascites, cholestasis, coagulopathy. Let me show you a few pictures. So you should look at this pathology as just high pressure damaging the portal veins. So the endothelium is damaged. So you get hemorrhage in the perivenular space. The same thing here, then it will be a secondary inflammation and there will be fibrosis. Later stages, there might be atrophy of the portal veins, and other portal veins may be dilated due to compensatory phenomena. And these are the same things. You can also get, if the hepatic artery undergoes severe spasm, you can get changes of even bile duct obstruction-like features with cholestasis. And here's that artery which I showed you. So if there's a severe portal hypertension, damage to the veins, the arteries can go in spasm, and that can cause biliary complications. And you can see this hemorrhage around the portal vein wall, and this is ulceration and hemorrhage of the common bile duct, and this is a stricture seen on radiology. So this is similar somewhat to the malignant hypertension changes in the kidney. If a vascular system in any organ sees a lot of pressure, that itself triggers a lot of pathology. So let's take it. Now, what about post-transplant infections? The timing is important. In the first post-transplant month, you typically get bacterial, soft tissue, abdomen, lung infections, and the urogenital infections. You can also get infections derived from the donor, such as fungal and mycobacterial. Later on, let's say from 1 month to 6 months, you see other pathogens, such as tuberculosis, gram-positive or negative bacteria, Hep C, Hep B, herpes, adenocardia, so on. After 6 months, the commonest infections are community-acquired pneumonias, urinary tract infections, and then late presentations of different viruses, including cytomegalovirus, EBV, herpes, pneumocystis, or fungi. So bacterial infections within the allograft will present as ascending cholangitis with an underlying duct complication or ischemia reperfusion injury with a biliary tree. You can get abscess cavities. And one of the causes of an abscess in the liver is appendicitis. or it could be diverticulitis. Those are common conditions in the population. So when you see a liver abscess, make sure you're not missing these. And less commonly, it might be hepatic artery thrombosis. Here's an example of an abscess formation within the liver. You should remember gram stains can be done on liver biopsies. They are not always useful. Sometimes the clinician already knows a culture is positive. Once in a while, they can demonstrate unusual organisms, such as Clostridia, such as bacteroids, and so you can come out looking like a hero. Oh, I made this diagnosis. You have to remember granulomas, you have to remember acid-fast bacilli in the right context. Within 30 days of transplantation, you must remember the donor-derived infections, fungal infections. Candida often can contaminate preservation fluids. The donor lung can be colonized with Candida, and that Candida might reactivate if you give that organ. Cryptococcus can be transmitted if the donor has an undiagnosed meningoencephalitis. So whenever you're considering a donor which has a serious encephalitis, you have to remember and make sure that you're not transmitting a serious fungal infection. And similarly, in our area, in the Pittsburgh area, histoplasmosis is endemic in the Ohio Valley area. And it's not uncommon for us to see little granulomas. Sometimes we are called for a frozen section. What is this granuloma? They're worried about a tumor. We say it is a granuloma. If it's scarred, then there's nothing to worry. If it's active, we tell them, but they may still use it. But then in those cases, they cover the patient for the first several weeks with an antifungal treatment. Invasive fungal infections not related to the donor, the incidence can vary depending on the setting. And there are risk factors such as diabetes, long ICU stay, prolonged surgery, delayed graft function, sepsis, CME disease, heavy immunosuppression, chronic kidney disease, acute kidney disease, acute liver failure, ARDS, shock. They can occur at any sites. The mortality is high. With Cryptococcus, it might be 25%, Candida 30 to 50, Aspergillus mucor 60 to 90%. I don't have to show these to you, but as a quick review for the younger people in the audience, Candida, mixture of yeast forms and pseudohyphae. Mucicarmin positive yeast are Cryptococcus. A yeast with a very thin, narrow budding are Histoplasma. Septate fungus with dichotomous branching is Aspergillus. And broad, non-septate, paper tissue-like septae are mucor. And as I mentioned earlier, the pathologist can sometimes give these diagnoses within 6 hours of the biopsy, whereas a culture may not even come positive if the fungus is dead, or it may take 3 or 4 weeks before you get the result. Let us now start talking about acute T-cell mediated rejection. It may be defined as a cell-mediated immune reaction to a foreign organ, but it's not always progressive or harmful. There's subclinical rejection, and then there's low-grade smoldering rejection. You have to remember that. And in some experimental models, rejection actually precedes the development of tolerance. So it's a dynamic process. Start. Oh, here it is. So this is to show the dynamic nature of the rejection process. If you plot the immune reaction like this on the y-axis and follow it with time, you have to recognize rejection is not yes or no, it's a continuum. So what you have to do is define what is the clinically actionable threshold. So if you put that threshold here along this line, some people will go above the threshold and will not come down till you treat it. Some people will just go a little above and they can even recover spontaneously. And there's a lot of fluctuation below the threshold, which you can diagnose with protocol biopsies. So the clinical presentation of T-cell mediated rejection may be subclinical, as I mentioned, or it can manifest as GGT and AP elevations, which are disproportionate to the AST and ALT. Severe cases may have fever, jaundice, encephalopathy, graft tenderness, leukocytosis, and eosinophilia. Most episodes occur within 7 to 10 days or maybe a few weeks, I would add. The pathology is usually a mixed, but mostly mononuclear infiltrate with duct injury, with inflammation of the venules and arteries. And it's suggested that at least 2 of these 3 criteria be present for a firm diagnosis. It's not enough to simply call a biopsy PCMR present, absent, you grade it. So because the grade determines the intensity of the treatment you have to give. So the parameters for grading are severity and distribution of inflammation, disruption of the lobular architecture, presence of arthritis, hemorrhage, necrosis. There are grades of PCMR. I can briefly read them. Indeterminate is something short of mild. In mild, the infiltrate should involve a minority of the triads or centrizonal areas, generally with the absence of confluent necrosis. In moderate, most of the portal tracts or perivenular area should be involved. Dropout should occur in a minority, and in a severe, there's spillover and there is centrizonal necrosis. But this is a continuum. The best way of grading is not to have a chart before you, but to use your experience and say this biopsy is in the lower third or middle third or upper third of the most severe cases. If you start reading these rules, they are sometimes difficult to apply. What is minority? What is majority? And sometimes there are only 7 portal tracts in a biopsy. Sometimes there are 27. So the percentages cannot be used in a very literal way. But some guidelines are better than no guidelines. And as you know, we score inflammation in the portal tracts from 0 to 3, duct damage from 0 to 3, endothelial inflammation from 0 to 3. So we can give a score of 9. And typically a mild rejection is 3 to 4, severe is 7 to 9. And I won't really go into the details of how you score these portal inflammations. Let's skip it for the sake of time. This would be an example of very indeterminate rejection. Important rejection is seen at the low power. If you're not an experienced pathologist, you go at 40x, you can go at 100x and see a lymphocyte in the bile duct in every biopsy. So you have to do it at 4x, 2x. If you see it there, that is clinically meaningful rejection. So this is an example of going to the high power showing a few cells. It doesn't matter. It's not even indeterminate actually. This is mild. This would be an example of moderate. The portal tracts are expanded and the ducts are also clearly the nuclei are irregularly spaced and there's loss of polarity. And the severe is this perivenular hemorrhage and dropout. But again, this perivenular hemorrhage and dropout can take varying degrees. Sometimes it's just 2 or 3 cells. So are you going to call it grade 3? No. So that's where you have to use your overall judgment and not just say there is venulitis so in the central vein, so I'm going to call it grade 3. This is severe duct damage. Now, atypical presentations of acute T-cell mediated rejection include late onset PCMR, plasma cell rich rejection, and rejection presenting as Budd-Chiari syndrome. So if there is severe central venulitis, which is around the zone 3, the presentation of acute rejection can be a Budd-Chiari syndrome with ascites, splenomegaly. And usually they have pretty dramatic central venulitis and need urgent treatment. So the late rejection is variably defined. Some people would say more than 100 days, some people might say 6 months. So in later rejection, there are fewer blasts. There is more interface activity. It starts looking a little bit like hepatitis. There is more perivenular inflammation, less of the actual damage and necrosis. And the lobule starts looking reactive, starts looking like hepatitis C. And this is because of the diversification of the immune response. As a graft continues to be in the body starts reacting not just to the portal tracts, not just to the veins, but also to the lobules. So it starts looking like hepatitis. And so the determination of whether it's hepatitis or rejection again will depend on the clinical context. These days, of course, recurrent hepatitis C is not really a problem, nor is recurrent hepatitis B. So most of the time, these lobular infiltrates will be seen in late rejection. Another term that's used for it is called idiopathic allograft hepatitis. Plasma cell rejection, rich rejection, usually there are various definitions. Some people want more than 30% of plasma cells. Usually the scores are high. If you do subsets of immunoglobulins, often there's an IgG4 clone. You can get lymphocytic cholangitis. You should, before you make a diagnosis of plasma cell rich rejection, you should ask for the original disease. If the original disease is autoimmune hepatitis, then you at least have to suggest this may be a recurrence of the autoimmune hepatitis. And then you can do a C4D, ask for DSA to see what is the cause. This is an example of very severe plasma cell hepatitis with central venulitis and dropout and interface activity. The grading of acute rejection, I think I've done it. Yes. What are the lesions which mimic acute T-cell mediated rejection? Recurrent hepatitis C, autoimmune hepatitis. I've shown you some of these. Recurrent PBC, CMV. Let me just show you them to you. So in recurrent hepatitis C, the inflammation spares the ducts. And you might get lymphoid aggregates, which are actually a little bit away from the ducts. You would see a lot of interface activity. This is actually from several years ago. This is cholestatic hepatitis C recurrent in the liver. The same case, cholestatic hepatitis with severe ballooning degeneration and canalicular plugging. If you see central venulitis and dropout, then the conventional teaching is this is not hepatitis, this is rejection, but it can be recurrent autoimmune hepatitis. Because if alloimmune hepatitis can damage the portal vein and the central vein, the autoimmune hepatitis can do the same thing in the same area. Recurrent PBC, if there's a granulomatoid infiltrate in the portal tracts, if there's lymphocytic cholangitis, if the ducts are showing what is known as eosinophilic transformation, they look very pink, then you have to think of recurrent PBC. And as I noted, we often do the cytokeratin 7 stain and show that there's ductal metaplasia around the ducts. And one other stain we use is S100 or CD1A. So these are ducts infiltrated by Langerhans type cells or dendritic type cells, because in autoimmune disease, this is just a thing we do. It's not well established in the literature. We are in the habit of doing it to support diagnosis. CMV is no longer seen very commonly, but you don't want to be the person who misses it. And so here is a bile duct. Probably, I can't even actually tell you what cell is infected. It might be a ductal epithelium, might be a macrophage, might be a hepatocyte. You can't say once there's so much cytomegaly, and there's the halo, and they will tend to be a few neutrophils. So in olden days, whenever there was a cluster of neutrophils in the lobule, we would stain for CMV hepatitis. And early on in the 90s, I would see 4 to 5 CMV hepatitis every week in a program which had 600 liver transplants. I haven't now seen CMV hepatitis in the past several years. There's all CMV reactivation. The PCR comes positive, they treat it, it goes away. Then, of course, there's GI disease, probably, and a little bit of liver disease too, but it's mostly now a thing of the past. And yes, PTLD. So whenever you have a biopsy which is blue, most of the time it's going to be rejection. But every day you have to at least keep it in the back of your mind, because otherwise the day PTLD comes, you're going to call it rejection. And that's not going to be good for your reputation. So the clues that I give people is, see if the infiltrate looks nodular. You see, this looks like an expansile infiltrate. Looks like there's a clone of lymphocytes which is proliferating. So if you see this, it should cross your mind. Oh, is it PTLD? Then if there is this irregular serpiginous or geographic necrosis, if the lymphocytes start growing very fast, they outstrip their blood supply. So late stages, it won't be seen early disease. But if you see this, then again, you have to start worrying. This is PTLD. And of course, higher power will look different. You'll get the sense that I'm dealing with a lymphoma. But of course, you also have really well differentiated, PTLDs, which are plasma cell rich. They will just look like an EBV syndrome. It's a whole spectrum, but these are the cases which you should not miss because they are obvious. And then EBER is a very good stain to diagnose EBV hepatitis. And then you should also do and very important, you do the CD3 and an L26. TCMR is mostly T cells by definition, and L26, most PTLDs are EBER positive, and CD26, CD20 positive, and you take them with rituximab. Of course, we have to remember they are T cell PTLDs, and there are T cell rejections which have a lot of B cells, but as a general guideline. So now I'll talk of ABMR, and I think I can cut this short substantially because it's already been covered by Dr. Vid. So in our experience, pre-existing DSAs are seen in 8 to 33%, de novos in 8 to 15%. DSAs can fluctuate. Graft ringi typically occurs with high titers, and as I said, most of them is a mixed rejection. The clinical presentation of acute ABMR can be a rejection which was thought of as TCMR, but is not responding to treatment. Remember, it can present as a bile duct problem, as a hepatic artery thrombosis, and as portal hypertension. Low platelets, low complements are clues that you may be dealing with ABMR. Basic histopathology has been shown, it's microvasculitis. So I think I can skip many slides, though I might make a few points here and there. The diagnostic criteria were meant, already covered. So I think I can get through much of this. I can just give you some pictures. This is a 1+ microvascular inflammation, 3 to 4 cells per capillary, 5 to 10 cells here. And this is a diffuse C4D, and this is endothelial disruption, 3+ microvascular inflammation, arteritis. Now, arteritis, in the context of ABMR, as I mentioned, if you do immunohistochemistry, even arteritis has a lot of things and a lot of macrophages. So always remember, ABMR has a significant T cell component to the injury, and most people will probably benefit from the usual steroid therapy and even thymoglobulin if indicated clinically. Chronic rejection wasn't covered. Let me do a little bit of that. This is a persistent progressive immune injury. The incidence was very high in the past, but now it's said to be very uncommon. But if you start talking of milder forms of chronic rejection, such as idiopathic hepatitis, such as perivenular sclerosis, such as focal C4D, they are probably commoner than is currently recognized. But maybe we don't have to overemphasize them to the clinician because otherwise they may get concerned. But like PCMR, ABMR is also a spectrum, with the earlier stages probably deserving nothing more than observation. So I can skip these risk factors. Yes, these are the pathology criteria for chronic rejection. In the ducts, the early lesions are atrophy and senescence, and the late lesions are duct loss, more than 50%. Central veins, early lesions are intimal inflammation, mild perivenular sclerosis. Late lesions are obliterated veins, bridging fibrosis. The lobule can have a hepatitic-like pattern, but later there is foam cells and cholestasis. There's also loss of hepatic arteries, just like this, loss of ducts. So I can show you some pictures. This is what we call senescent changes. The bile ducts don't look healthy. And my boss has this expression, it looks like somebody poured acid down this biliary tree. And that's why the bile ducts are looking so unhappy. We find the P21 stain as a helpful indicator of senescence. And usually the Ki67 proliferation index will be low. So if you think that a duct is senescent, then it should have a low Ki67 or a MIB1 and a high P21. So this is another subjective thing we do. It's not written in any book, but we do these stains to help make assessments whether these ducts are damaged. And here's an example of ductopenia. And here's an example of centrizonal cholestasis and dropout in later stages of chronic rejection. So presumably this liver has severe graft arteriosclerosis, and it's like there might even be hepatic artery thrombosis on top of that chronic rejection. So that's what we see here. So chronic rejection in the liver cannot be diagnosed as readily as in the kidney, because most of the time the arteries are not available for evaluation, the large ones at least. And this is the later stage of chronic rejection with perivenular sclerosis and dropout. And I think I can skip many of these criteria because they have already been covered. And so what the hallmark of chronic rejection in the arteries is graft atherosclerosis. So here's a graft which came out a long time ago. And these atheromatics plaques are actually quite similar to the atheromatics plaques you see in, let's say, in native coronary artery disease. Coronary arteriosclerosis is eccentric, but graft arteriopathy is concentric because the immune system acts equally on all the sides. So that's one difference to be aware of. Chronic rejection can cause biliary pathology. I mentioned that, so I don't have to re-stress it. And here is an example of bile duct necrosis and extravasation of the ducts in chronic rejection. You can get fistulas, which I've already shown you. So let me just review my talk. So the diagnostic entities that you can identify in a biopsy are acute T cell rejection, which depends on portal, ductular, venular inflammation. Preferably 2 out of 3 criteria should be satisfied. For antibody rejection, you need microvascular inflammation, C4D, TSA. Atypical forms of rejection must be remembered. Late acute rejection, plasma cell-rich rejection, Budd-Chiari-like presentation. We have to beware of mimics of rejection, PTLD, recurrent disease. Then chronic rejection has to be diagnosed with ductopenia in the presence perhaps of strictures, infarction, biliary vascular fistulas. And then very important, the pathology, radiology, surgery, and hepatology teams must always work together, have good communication, so that the biopsy findings can be interpreted in the right context. Just like there is no symptom or physical sign which is pathognomonic of one disease. Similarly, there is no pathology lesion which can only happen in one disease. So that's why there are hundreds of diseases mentioned in the textbooks. There are maybe only 20 or 30 lesions which a pathologist can recognize. So it is absolutely vital that the pathologists and the clinicians, they work together so they can come up with the best possible diagnosis for the lesions that you're seeing in those biopsies. Here's a sample report. For example, in a report, we might say mild T-cell mediated rejection, rejection activity index 3/9. If there's also an antibody rejection on top of it, we would say acute antibody rejection, microvascular inflammation score 1+, T4D score 1+. If there's more than one insult present, we will add it. For example, in the morning, I commented that somebody had a pathology report saying no evidence of rejection. Well, that's fine, but also see what evidence is there and what are you interpreting that evidence as. So your job is not to just say rejection, yes, no. You are a much more competent person. You can look at all the histopathology lesions, combine it with the clinical diagnosis, and help actually even the clinicians lead to a proper diagnosis. And so then we would probably say, oh, there are also changes consistent with duct stricture. And then it's very important to compare it with the previous biopsies. For example, we will say this RAI index 3/9 is improved compared to a previous biopsy, where it might have been 6/9, and this might be a post-steroid treatment. Or we might say recurrent hepatitis C seen in the previous biopsy has progressed to cirrhosis. So that's how a good pathology report can really enhance clinical management. And so I will stop here and ask, is there any question?